Question 1. Contrast media and pharmacology. A 65-year-old patient with chronic kidney disease, CKD, stage 3 requires contrast-enhanced CT angiography for suspected pulmonary embolism. The radiologist is considering the use of an iodinated contrast agent. Which of the following strategies is the most appropriate to minimize the risk of contrast-induced nephropathy, SIN? A. Administer intravenous normal saline hydration before and after the contrast study. B. Use a high-osmolar contrast agent to improve vascular delineation. C. Proceed with the study without special precautions since the risk of SIN is negligible in CKD stage 3. D. Substitute iodinated contrast with gadolinium-based contrast to avoid nephrotoxicity. Answer A. Administer intravenous normal saline hydration before and after the contrast study. Explanation. Contrast-induced nephropathy, SIN, is a significant risk in patients with pre-existing renal impairment. The European Society of Urogenital Radiology (ESRA) recommends pre- and post-hydration with isotonic fluids, normal saline or bicarbonate solution as the primary preventive measure. High-osmolar contrast agents, option B, are associated with a greater risk of nephrotoxicity compared to low-osmolar or iso-osmolar agents and should be avoided in high-risk patients. CKD stage 3 EGFR 30 44 ml on 0.73 does carry an increased risk of SIN. Option C is incorrect. While gadolinium-based contrast agents (GBCAS) can be nephrotoxic, they pose risk of nephrogenic systemic fibrosis (NSF). Patients with advanced renal impairment, making them unsuitable as an alternative to iodinated contrast. Option D is incorrect. Question 2. Neuroradiology. Stroke imaging scenario-based. Dr. Patel is evaluating 58-year-old male who arrived at the emergency department with an acute onset of right-sided weakness and speech difficulty 2 hours ago. Non-contrast CT scan of the brain shows no hemorrhage, but subtle loss of grey-white differentiation in the left middle cerebral artery and Chi territory. The patient's NIS stroke scale. NIS score is. What should be the next step in management? A. Administer intravenous thrombolyserum EPA immediately. B. Obtain CT angiogram ETA of the head and neck to assess large vessel occlusion. C. Repeat the non-contrast CT in 6 hours to reassess for infarction. D. Perform digital subtraction angiography (DSA) and proceed directly to mechanical thrombectomy. Answer B. Obtain an angiogram CTA of the head and neck to assess large vessel occlusion. Explanation. In patients presenting with acute ischemic stroke symptoms within 4.5 hours of onset, intravenous thrombolysis with alteplase EPA is indicated if there are no contraindications. However, in cases with suspected large vessel occlusion LVO e.g. NIS6 cortical symptoms, a angiogram (TAG) performed to identify LVO before proceeding to thrombectomy. Option is incorrect because EPA are appropriate. Ruling out LVO with ETA is essential before deciding on additional endovascular treatment. Option C, delayed reput CT, is inappropriate since stroke intervention is time sensitive. Option D, DSA, is premature without confirming LVO or TA first. The European Stroke Organization (ESO) and American Heart Association (AHA) guidelines recommend a TA in all suspected LVO cases, followed by mechanical thrombectomy if an occlusion is present. Question 3. Musculoskeletal radiology. Bone tumors. 35-year-old female presents with chronic knee pain and swelling. An X-ray of the distal femur reveals sunburst periosteal reaction with common triangle and osteoid matrix formation. What is the most likely diagnosis? A. Osteochondroma. B. Osteosarcoma. C. Giant cell tumor. D. Chondrosarcoma. Answer B. Osteosarcoma. Explanation. Osteosarcoma is the most common primary malignant bone tumor in young adults and is characterized by aggressive periosteal reactions, sunburst appearance, common triangle, and osteoid matrix formation on imaging. Obstrucous osteochondroma is a benign bone tumor that appears as an exostosis with a cartilage cap lacking aggressive periosteal reactions. Option C, giant cell tumor, occurs at the epiphyseal end of long bones and lacks osteoid matrix formation. Option D, chondrosarcoma, typically presents in older patients and shows chondroid rather than osteoid matrix on imaging. According to the World Health Organization, WHO, bone tumor classification, osteosarcoma requires a multimodal approach involving neoadjuvant chemotherapy, surgical resection, and sometimes radiotherapy. Question 4. Musculoskeletal radiology. Bone tumors. 45-year-old male presents with persistent pain and swelling in his distal femur. Radiographic evaluation reveals lytic lesion with wide zone of transition, periosteal reaction forming Commons triangle, and cortical destruction. MRI with contrast shows heterogeneously enhancing mass with soft tissue extension. Biopsy confirms high-grade osteosarcoma. Which of the following imaging findings is most characteristic of an aggressive primary malignant bone tumor? A. Geographic lytic lesion with well-defined sclerotic margins. B. Moth-eaten or permeative bone destruction with periosteal reaction. C. Benign appearing in chondroma with internal calcifications. D. Subchondral cystic changes with osteophytes in the joint. Answer: B. Moth-eaten or permeative bone destruction with periosteal reaction. Explanation: primary malignant bone tumors, such as osteosarcoma, typically present with aggressive bone destruction patterns, including moth-eaten or permeative destruction, a wide zone of transition, and periosteal reactions like Codman's triangle. Option A is incorrect because geographic lesions with sclerotic margins are characteristic of benign or low-grade lesions such as fibrous dysplasia or non-ossifying fibroma. Option C is incorrect as in chondromas are benign and typically exhibit internal calcifications and well-defined borders. Option D is incorrect because subchondral cystic changes and osteophytes are associated with osteoarthritis, not primary malignancy. Reference: WHO Classification of Tumors of Bone 2020 and the Necking Staging System for Bone Tumors emphasize the role of imaging in differentiating aggressive versus benign lesions. Question 5. Interventional radiology. Emergency embolization. 58-year-old male with history of liver cirrhosis presents with hematemesis and hemodynamic instability. Emergency endoscopy reveals gastric varicose bleeding refractory to band ligation. The patient is transferred for interventional radiology assessment. Which of the following is the most appropriate interventional radiology procedure for managing this condition? A. Transjugular intrahepatic portosystemic shunt tapes. B. Percutaneous transhepatic biliary drainage. C. Inferior vena cava I filter placement. D. Thoracic endovascular aortic repair TEVA. Answer: A. Transjugular intrahepatic portosystemic shunt TIPS. Explanation: TIPS is the gold standard for managing refractory variceal bleeding, particularly in cirrhotic patients. It creates a low resistance shunt between the portal and hepatic veins, reducing portal hypertension and preventing recurrent bleeding. Option B is incorrect because percutaneous transhepatic biliary drain PED is used for biliary obstruction, not varicose bleeding. Option C is incorrect since IV filters are indicated for deep vein thrombus DVT prevention, not variceal bleeding. Option D is incorrect as TEVA is a treatment for thoracic aortic aneurysm or dissection unrelated to varicose hemorrhage. Reference: Neuroman and Census for the management of portal hypertension and variceal bleeding. Question 6. Oncologic imaging. RECIST criteria. 62-year-old female undergoing chemotherapy for metastatic breast cancer undergoes follow-up CT to assess tumor response. The oncologist wants to determine if the lesions have responded to treatment based on RECIST response evaluation criteria in solid tumors 1.1 guidelines. Which of the following is considered progressive disease PD according to RECIST? Point 1. A. At least 30% decrease in the sum of target lesion diameters. B. Complete disappearance of all target lesions. C. At least 20% increase in the sum of target lesion diameters with an absolute increase of at least 5 mm. D. Development of new lesion but no change in the original target lesions. Answer: C. At least a 20% increase in the sum of target lesion diameters with an absolute increase of at least 5 mm. Explanation: RECIST 1.1 defines progressive disease PD as a 20% increase in the sum of diameters of target lesions with an absolute increase of at least 5 mm or the appearance of new lesion. Option A is incorrect because 30% decrease defines partial response PR, not progression. Option B is incorrect since complete response CR means the total disappearance of lesions. Option D is partially correct but incomplete. New lesions alone may indicate progression, but measurement changes in existing lesions must be considered. Reference: RECIST 1.1 Guidelines, European Society of Radiology and Oncology. Question 7. Artificial intelligence in radiology. Which of the following best describes the most common limitation of artificial intelligence (AI) in radiology today? A. AI models demonstrate A perfect accuracy rate in detecting malignancies. B. AI cannot yet integrate with PACS and radiology workflows. C. AI models are susceptible to biases due to variability in training data. D. AI completely replaces radiologists in clinical practice. Answer: C. AI models are susceptible to biases due to variability in training data. Explanation: AI in radiology has advanced significantly but remains prone to biases, especially when trained on limited datasets that do not represent diverse populations. Option A is incorrect because AI does not achieve 100% accuracy and often requires radiologist oversight. Option B is incorrect as modern AI algorithms integrate seamlessly with PACS, RIS, and workflow systems. Option D is incorrect since AI currently assists radiologists rather than replacing them. Reference: European Society of Radiology AI Task Force Guidelines. Question 8. Stroke imaging. Hyperacute stroke. 67-year-old male presents with sudden left-sided weakness and facial droop for the past 2 hours. Non-contact A CT of the brain shows no hemorrhage, but CT angiography (ETA) reveals an occlusion of the right middle cerebral artery (MACI). The patient is eligible for thrombolysis. Which imaging modality should be used next to assess infarct, core, and penumbra? Mechanical thrombectomy (MRI) with diffusion-weighted imaging (DWI) and perfusion imaging. B. Standard non-contrast CT/LE. C. X-ray of the skull. D. Ultrasound Doppler of the carotid arteries. Correct answer: MRI with diffusion-weighted imaging, DWI, and perfusion imaging. Explanation: MRI, DWI, and perfusion imaging are the gold standard for identifying the infarct core versus penumbra, guiding mechanical thrombectomy decisions in patients presenting within 24 hours of symptom onset. Option B is incorrect because SET alone cannot distinguish penumbra from infarcted tissue. Option C is incorrect as X-ray has no role in stroke imaging. Option D is incorrect because carotid Doppler assesses extracranial carotid disease but does not determine infarct viability. Reference: 2018 Hausa Stroke Guidelines and the Dawn Diffuse 3 trials. Question 9. Pediatric radiology. Congenital diaphragmatic hernia (CH), newborn male, is delivered at 38 weeks via C-section due to polyhydramnios detected on prenatal ultrasound. The baby presents with severe respiratory distress immediately after birth. Chest X-ray reveals left-sided mediastinal shift, scaphoid abdomen, and multiple gas-filled loops in the left hemithorax. Which of the following is the most? Diagnosis: A. Congenital lobar emphysema. B. Congenital diaphragmatic hernia (CH). C. Neonatal pneumonia with pneumothorax. D. Esophageal atresia with tracheoesophageal fistula. Answer: B. Congenital diaphragmatic hernia (CH). Explanation: CH results from failure of the diaphragm to close, leading to herniation of abdominal contents into the thorax. Key radiographic features: bowel loops in the thorax, mediastinal shift, and a scaphoid abdomen. Option A is incorrect because congenital lobar emphysema presents with a hyperinflated lung, not bowel loops. Option C is incorrect because neonatal pneumonia with pneumothorax would show lung consolidation with air leaks but no bowel loops. Option D is incorrect because esophageal atresia does not cause bowel herniation into the chest. Reference: American College of Radiology, ACA Pediatric Imaging Guidelines. Question 10. Breast imaging. BI-RADS classification. 50-year-old woman undergoes routine screening mammography. The report describes spiculated mass with architectural distortion, categorized as BI-RADS 5. Which of the following is the most appropriate next step? A. Routine follow-up mammogram in 6 months. B. Short-term ultrasound follow-up. C. Core needle biopsy under imaging guidance. D. No further evaluation is needed. Answer: C. Core needle biopsy under imaging guidance. Explanation: BI-RADS 5 lesions have 95% likelihood of malignancy and require immediate biopsy for histopathologic confirmation. Option A is incorrect because routine follow-up is not appropriate for a suspicious lesion. Option B is incorrect as BI-RADS 5 lesions require immediate tissue sampling, not just ultrasound monitoring. Option D is incorrect because no further evaluation is not a viable option in suspected malignancy. Reference: American College of Radiology BI-RADS Atlas. Question 11. Neuroimaging. Multiple sclerosis MSMRI. 32-year-old woman presents with numbness and weakness in her right leg. For 2 weeks, MRI brain and spine reveal multiple ovoid periventricular lesions oriented perpendicular to the ventricles, Dawson's fingers, and enhancing lesions in the cervical spinal cord. Which of the following MRI sequences is most sensitive for detecting demyelination in multiple sclerosis? A. Weighted sequence. B. Gradient echography. C. Diffusion weighted imaging. D. Flare, fluid attenuated inversion recovery. Answer: D. Flare, fluid attenuated inversion recovery. Explanation: Flare is the most sensitive MRI sequence for detecting demyelinating plaques in MS, particularly in the periventricular and juxtacortical regions. Option A is incorrect because weighted imaging does not highlight demyelination effectively. Option B is incorrect as GRI is more useful for hemorrhage detection. Option C is incorrect because TWI is mainly used for acute infarct, not chronic demyelination. Reference: McDonald Criteria for MS Diagnosis 2017. Question 12. Abdominal imaging. Pancreatic cancer staging. 65-year-old man with unintentional weight loss and jaundice undergoes contrast-enhanced CT pancreas. Imaging reveals hypertenuating mass in the pancreatic head with encasement of the superior mesenteric artery, SMA 108 but no distant metastasis. According to SECN guidelines, which of the following is the most appropriate treatment option? A. Surgical resection with pancreaticoduodenectomy, Whipple. B. Neoadjuvant chemotherapy with possible surgical reassessment. C. Radiation therapy alone. D. Palliative care without intervention. Answer: B. Neoadjuvant chemotherapy with possible surgical reassessment. Explanation: Locally advanced pancreatic cancer, SMA encasement 108 is initially unresectable and requires neoadjuvant therapy before reassessment for surgery. Option A is incorrect because SMA involvement 108 precludes upfront surgery. Option C is incorrect as radiation alone is not the preferred first-line approach. Option D is incorrect because the patient may still qualify for treatment. Reference SEN guidelines for pancreatic adenocarcinoma. Question 13. Nuclear medicine. Thyroid scintigraphy. 45-year-old woman presents with painless thyroid nodule and suppressed TSH levels. 99 per technetate thyroid scan reveals cold nodule in the right lobe. Which of the following is the most appropriate next step? A. Fine needle aspiration, FNA, biopsy. B. Empirical thyroid hormone replacement. C. Radioactive iodine therapy. D. CT scan of the thyroid. Answer: A. Fine needle aspiration, FNA, biopsy. Explanation: Cold nodules have a higher risk of malignancy and require FNA biopsy for histologic evaluation. Option B is incorrect because empirical thyroid hormone replacement is not indicated without biopsy confirmation. Option C is incorrect as radioactive iodine is used for hyperfunctioning hot nodules, not cold ones. Option D is incorrect since CT is not first line for thyroid nodules. Reference: American Thyroid Association, OTA, Guidelines. Question 14. Chest imaging. Pulmonary embolism, P. Diagnosis. 56-year-old woman with recent surgery presents with acute dyspnea, tachycardia, and pleuritic chest pain. CT pulmonary angiography, E/PA, reveals filling defect in the right main pulmonary artery. Which of the following signs is most specific for pulmonary embolism on CT? A. Hampton's hump. B. Westermarck sign. C. Central filling defect within pulmonary artery. D. Ground glass opacity in dependent lung zones. Answer: C. Central filling defect within a pulmonary artery. The explanation: E/PA is the gold standard for P diagnosis and a central filling defect is the most specific finding. Option A is incorrect because Hampton's hump is secondary sign of pulmonary infarction, not specific for P. Option B is incorrect since Westermarck sign is only suggestive but not definitive. Option D is incorrect because ground glass opacities are non-specific. Reference: Pupt Roman 2 Tuddy for P imaging. Question 15. Musculoskeletal imaging. Osteomyelitis diagnosis. 45-year-old diabetic male presents with chronic non-healing ulcer on the plantar surface of his foot. X-ray shows cortical irregularity and periosteal reaction of the underlying metatarsal bone. Which of the following imaging modalities is most sensitive for the early detection of osteomyelitis? A. X-ray. B. CT scan. C. MRI. D. Bone scintigraphy. TC 99 meters. Answer: C. MRI. Explanation: MRI is the most sensitive and specific modality for detecting early osteomyelitis, showing bone marrow edema and soft tissue involvement before cortical changes appear on X-ray. Option A is incorrect because X-ray changes, periosteal reaction, bone destruction appear late. Option B is incorrect because CT is less sensitive for detecting bone marrow changes. Option D is incorrect because bone scintigraphy is sensitive but lacks specificity. Reference American College of Radiology, ACA appropriateness criteria. Question 16. Gastrointestinal imaging. Bowel obstruction on CT. 65-year-old woman presents with abdominal distension, vomiting, and constipation for 3 days. CT abdomen reveals dilated small bowel loops with transition point at the terminal ileum and thickened, hyperenhancing bowel wall with mesenteric edema. Which of the following is the most likely cause of the obstruction? A. Volvulus. B. Intussusception. C. Adhesions. D. Strangulated hernia. Answer C. Adhesions. Explanation. Adhesions are the most common cause of small bowel obstruction (SBO), especially in patients with a history of prior abdominal surgery. Option A is incorrect because volvulus typically causes a whirl sign on CT and is more common in the sigmoid colon or cecum. Option B is incorrect since intussusception presents with target sign and is rare in adults. Option D is incorrect because strangulated hernia would show bowel incarceration at the hernia site. Reference Radiology Society of North America (SNI) Abdominal Imaging Guidelines. Question 17. Thoracic imaging. Pneumothorax on chest X-ray. 28-year-old male presents with sudden onset chest pain and dyspnea. He has no history of trauma. Chest X-ray in expiration shows visible pleural line without lung markings beyond it. Which of the following best describes the underlying pathophysiology? A. Alveolar overdistension leading to rupture. B. Inflammatory pleural thickening. C. Pulmonary venous congestion. D. Bronchial wall thickening and obstruction. Answer A. Alveolar overdistension leading to rupture. Explanation. Spontaneous pneumothorax is caused by rupture of subpleural bulbs or bulli, leading to air accumulation in the pleural space. Option B is incorrect as inflammatory thickening is seen in pruritus, not pneumothorax. Option C is incorrect because pulmonary venous congestion is seen in heart failure, not pneumothorax. Option D is incorrect because bronchial thickening is more characteristic of chronic bronchitis or asthma. Reference American Thoracic Society, its guidelines. Question 18. Head and neck imaging. Sinusitis complications. 42-year-old male with history of chronic sinusitis, presents with periorbital swelling, headache, and fever. CT sinuses reveal ossification of the ethmoid sinuses with orbital fat stranding and proptosis. Which of the following is the most likely diagnosis? A. Orbital cellulitis. B. Mucosal. C. Cavernous sinus thrombosis. D. Allergic fungal sinusitis. Answer A. Orbital cellulitis. Explanation. Orbital cellulitis is a serious complication of sinusitis characterized by post-septal fat stranding and proptosis on CT. Option B is incorrect because mucosals present as well-defined expansile lesions. Option C is incorrect because cavernous sinus thrombosis involves cranial nerve deficits and bilateral involvement. Option D is incorrect as allergic fungal sinusitis shows hyperattenuating fungal debris on CT. Reference American Journal of Neuroradiology, AJNA. Question 19. Genitourinary imaging. Nephrolithiasis on CT. 35-year-old male presents with acute flank pain radiating to the groin. Non-contrast CT abdomen reveals 4 mm hyperattenuating stone in the left uretero-vesical junction. Which of the following is the most appropriate management? A. Emergent lithotripsy. B. Ureteral stenting. C. Conservative management with hydration and pain control. D. Open surgical removal. Answer C. Conservative management with hydration and pain control. Explanation. Most stones 6 mm stones. Option B is incorrect as stenting is considered for obstructing stones with infection. Option D is incorrect because open surgery is rarely needed. Reference American Urological Association or guidelines. Question 20. Neuroimaging. Subarachnoid hemorrhage. So 50-year-old woman presents with sudden severe headache, thunderclap headache, CT head without contrast, reveals hyperdensity in the basal systems. What is the most likely cause? A. Arteriovenous malformation avum. B. Ruptured aneurysm. C. Cerebral venous sinus thrombosis. D. Ischemic stroke with hemorrhagic conversion. Answer B. Ruptured aneurysm. Explanation: aneurysmal rupture is the most common cause of spontaneous subarachnoid hemorrhage, especially in the anterior communicating artery. Option A is incorrect because AVMs cause intraparenchymal hemorrhage, not SAR. Option C is incorrect since venous thrombosis presents with venous infarcts, not basal cistern hemorrhage. Option D is incorrect because ischemic strokes typically present with focal deficits, not thunderclap headache. Reference: American Stroke Association ASA guidelines. Question 21. Chest imaging. Pulmonary embolism or EPA. 60-year-old male presents with sudden onset dyspnea and pleuritic chest pain. He has history of deep vein thrombosis. ET pulmonary angiography EPA reveals filling defect in the right main pulmonary artery. Which of the following is the best initial treatment? A. Intravenous heparin. B. Thrombolysis with tissue plasminogen activator (TPA). C. Surgical embolectomy. D. Inferior vena cava I filter placement. Answer A. Intravenous heparin. Explanation: unfractionated heparin or low molecular weight heparin is the first-line treatment for acute pulmonary embolism. P. Option B is incorrect because thrombolysis is reserved for massive P with hemodynamic instability. Option C is incorrect because surgical embolectomy is only considered for patients who fail thrombolysis. Option D is incorrect because if fills are used for recurrent EE when anticoagulation is contraindicated. Reference: American College of Chest Physicians Act guidelines. Question 22. Pediatric imaging. Intussusception on ultrasound. 9-month-old infant presents with colicky, abdominal pain, vomiting, and recurrent jelly stools. Ultrasound abdomen reveals target sign in the right lower quadrant. Which of the following is the preferred treatment? A. Emergency laparotomy. Roman antibiotics and observation. C. Air or contrast enema reduction. D. Appendectomy. Answer C. Air or contrast enema reduction. Explanation: non-surgical reduction with air or contrast enema is the first-line treatment for intussusception. Option A is incorrect because surgery is only required if non-operative reduction fails. Option B is incorrect because antibiotics do not resolve intussusception. Option D is incorrect because appendectomy is unrelated to this condition. Reference: American College of Radiology ACA Pediatric Imaging Guidelines. Question 23. Neuroimaging. Acute stroke and MRI. 72-year-old woman with sudden left-sided weakness and slurred speech undergoes an MRI brain, which shows diffusion restriction in the right middle cerebral artery in Mackay territory with no hemorrhage on gradient echo GRI imaging. What is the next best step in management? A. Administer EPA. B. Perform mechanical thrombectomy. C. Start aspirin and supportive care. D. Perform carotid endarterectomy. Answer A. Administer EPA. Explanation: Roman plasminogen activator (EPA) is the standard treatment for acute ischemic stroke if given within 4.5 hours of symptom onset. Option B is incorrect because thrombectomy is reserved for large vessel occlusions in eligible patients. Option C is incorrect because aspirin alone is not the first-line treatment in the acute phase. Option D is incorrect because carotid endarterectomy is a secondary prevention strategy. Reference: American Stroke Association ASA guidelines. Question 24. Abdominal imaging. Appendicitis on CT. 22-year-old male presents with right lower quadrant pain, nausea, and fever. CT abdomen with contrast shows dilated appendix 10 mm with periappendicial fat stranding. What is the most appropriate next step? A. Observation and antibiotics. B. Laparoscopic appendectomy. C. Percutaneous drainage. D. Colonoscopy. Correct answer B. Laparoscopic appendectomy. Explanation: acute appendicitis with radiologic findings warrants immediate surgical removal. Option A is incorrect because observation is only considered in select cases of uncomplicated appendicitis. Option C is incorrect because drainage is for periappendicial abscess, not acute appendicitis. Option D is incorrect because colonoscopy is contraindicated in acute infections. Reference: Society of American Gastrointestinal and Endoscopic Surgeons, SAGES. Question 25. MSK imaging. Rotator cuff tear on MRI. 55-year-old carpenter presents with chronic shoulder pain and weakness. MRI shoulder reveals full thickness tear of the supraspinatus tendon with muscle atrophy. Which of the following is the best management approach? A. Physical therapy and NSAIDs. B. Platelet-rich plasma PRP injection. C. Arthroscopic rotator cuff repair. D. Shoulder arthroplasty. Answer C. Arthroscopic rotator cuff repair. Explanation. Surgical repair is indicated for full-thickness tears in active individuals. Option A is incorrect because physical therapy is used for partial tears. Option B is incorrect as PRP has limited evidence in full-thickness tears. Option D is incorrect because arthroplasty is for severe arthritis, not rotator cuff tears. Reference: American Academy of Orthopedic Surgeons, Hours. Question 26. Breast imaging. BI-RADS 4 lesion. 48-year-old woman undergoes screening mammogram which reveals spiculated mass with irregular margins and microcalcifications. BI-RADS 4. What is the next step? A. Routine follow-up in 6 months. B. Core needle biopsy. C. Breast MRI. D. Mastectomy. Answer: B. Core needle biopsy. Explanation: BI-RADS 4 lesions require biopsy due to their suspicious features. Option A is incorrect because follow-up is not appropriate for suspicious lesions. Option C is incorrect because MRI is not the primary diagnostic tool in this scenario. Option D is incorrect because mastectomy is considered after a confirmed malignancy diagnosis. Reference: American College of Radiology, ACA, Breast Imaging Guidelines. Question 27. Vascular imaging. Abdominal aortic aneurysm. A 68-year-old male with history of smoking undergoes an abdominal ultrasound which shows an abdominal aortic aneurysm measuring 5.6 centimeters. What is the best next step? A. Observation with serial ultrasounds. B. Open surgical repair. C. Endovascular aneurysm repair of R. D. Start antihypertensive therapy. Answer C. Endovascular aneurysm repair of R. Explanation: They have 5.5 centimeters in men or 5 centimeters in women requires intervention. Option A is incorrect because surveillance is only for smaller aneurysms. Option B is incorrect because open surgery is reserved for patients who are not candidates for EVAR. Option D is incorrect because antihypertensives alone do not prevent rupture. Reference: Society for Vascular Surgery, SPS Guidelines. Question 20. Cardiac imaging. Aortic dissection on CT. 65-year-old man with history of hypertension and smoking presents with sudden severe chest pain radiating to the back. CT angiography of the chest reveals dissection flap in the ascending aorta extending into the aortic arch. Stanford type 8. Which of the following is the most appropriate management? A. Beta blockers and serial imaging. B. Emergent surgical repair. C. Endovascular stent placement. D. Anticoagulation therapy. Answer: B. Emergent surgical repair. Explanation: Stanford type dissections involve the ascending aorta and require immediate surgical repair due to the high risk of rupture. Option A is incorrect because medical management. Beta blockers is only appropriate for stable type B dissections. Option C is incorrect because endovascular stenting is primarily used for descending aortic dissections. Option D is incorrect because anticoagulation is contraindicated due to the risk of worsening the dissection. Reference: American Heart Association, AHA Guidelines. Question 29. Gastrointestinal imaging. Small bowel obstruction on abdominal X-ray. 45-year-old woman with history of prior abdominal surgery presents with crampy abdominal pain, nausea, vomiting, and obstipation. Abdominal X-ray shows multiple air fluid levels and dilated loops of small bowel. What is the next step in management? A. Immediate laparotomy. B. Nasogastric tube decompression Romanuids. A. Oral contrast enhanced CT scan. D. Colonoscopy. Answer: B. Nasogastric tube decompression Romanuids. Explanation: Most small bowel obstructions (SBO) are managed conservatively initially unless there are signs of strangulation or perforation. Option A is incorrect because immediate surgery is reserved for cases with peritonitis or ischemia. Option C is incorrect because CT is useful for further evaluation but is not the first treatment step. Option D is incorrect because colonoscopy has no role in SBO management. Reference: American College of Surgeons ACS Guidelines. Question 30. Head and neck imaging. Orbital cellulitis on CT. 10-year-old boy presents with fever, proptosis, decreased eye movements, and periorbital swelling. CT scan of the orbit shows post-septal fat stranding, proptosis, and sinusitis. Which of the following is the most appropriate next step? A. Roman antibiotics and close monitoring. B. Oral antibiotics and outpatient follow-up. C. Urgent surgical drainage. D. Lumbar puncture. Answer: Roman antibiotics and close monitoring. Explanation: orbital cellulitis requires immediate Roman antibiotics due to the risk of complications like abscess formation or cavernous sinus thrombosis. Option B is incorrect because oral antibiotics are inadequate for post-septal infections. Option C is incorrect because surgery is only needed if there is an abscess or worsening despite antibiotics. Option D is incorrect because lumbar puncture is not indicated in this scenario. Reference: American Academy of Ophthalmology. O. Guidelines.